Dr. Paras Patel is a board-certified oral and maxillofacial pathologist who obtained his dental degree from Howard University College of Dentistry in 2011. Dr. Patel went on to practice general dentistry for a couple of years in the Lubbock area, working on a mobile dental unit. In 2014, he began his residency in oral and maxillofacial pathology at TMU College of Dentistry. Upon completion of his residency, Dr. Patel took a position at the College of Dentistry and is currently a full-time faculty member in the Department of Diagnostic Sciences. He maintains a clinical practice actively seeing patients who suffer from various oral diseases in the Stomatology Center and is an active surgical pathologist in a busy biopsy service. Dr. Patel's previous work experience and curiosity have shaped his approach to diagnosis and management of disease. Please welcome Dr. Paras Patel.
Hi, everybody. Let me go ahead and share my screen here. There we go. Well, Beth, thank you for the introduction. It's been a pleasure to have this sort of opportunity and relationship with the Texas Oral Health Coalition and particularly to partake in the Texas Oral Health Conference. I should tell you that my information for my bio has been updated just a little bit. As of last week, I have actually transitioned out of the College of Dentistry and then in private practice here in Dallas, and also do a path service with a different medical group. So this is all my contact information. If need be, I always give my cell phone out just for any sort of, questions or concerns or anything that anybody does have. Myself as well as the other oral pathologists in the state of Texas are always available. You can get a hold of us. We're pretty approachable individuals. And again, we're here to serve, and it's a common goal to be able to provide any sort of insight we can for the residents of our state and even out of our state in the country. So that's my contact info. I always start these things off a little bit casually, and Beth knows this as well as some of the other folks. But I can't do what I do without these people. This is my daughter on the very, should be probably your right, in the car seat there, and my son. And this is a good day. My wife is also making a face, and this is the only time I get to make fun of her. So if anybody runs into her, please don't tell her that this photo is up here. So what are we going to be talking about today? So the title is Autoimmune and Immune-Mediated Conditions that Affect the Oral Cavity. And so what we're talking about here is pretty much inflammatory diseases, something that looks inflammatory that comes into your practice. And every member of our oral healthcare team, or people that aren't even part of this, but in the healthcare field in general, plays a critical role in evaluating the diseases that patients present with. And every piece of information is valid. That starts from the phone conversation when the patient schedules an appointment to the time that the actual provider sees the patient. And I really want to emphasize how important each individual is as part of this team. Oftentimes we have this mentality that everything is clinician-centric, and that's not the way it works. I rely on my staff as just as much as they rely on me to make sure that we provide proper healthcare for our patients. So what we're going to talk about is some really common entities that most of you guys have probably been familiar with. Geographic tongue, aphthous stomatitis, or an aphthous ulcer, also referred to as a canker sore. We'll talk about allergic reactions, which is a very important point that I do want to focus on, a disease process that's really variable and does deserve some time. Then we'll talk about some of the more common things we see under the category of desquamative gingivitis, which is lichen planus, pemphigus vulgaris, allergic reactions, as well as mucous membrane pemphigoid and lupus. Okay. So the first thing is geographic tongue. It goes by a handful of different names. People call it benign migratory glossitis or stomatitis, as well as erythema migrans. We always like these fancy terms. They're scientific. We learn them in school or in our training. And so it always makes us excited to use these terminologies, but we do have to be a little bit careful with the way we convey things to our patients. So what is this? This is an inflammatory process. We don't really know the true underlying factor that leads to this. Some studies have shown that there's an increased prevalence of geographic tongue with patients who have cutaneous psoriasis. And that's because they share certain HLA subtypes that we see frequently in both populations. In our practice, who are we going to see? Typically, there is a stronger female predilection for geographic tongue, but this can happen in males, and it can be seen at any age. It's less likely to be seen in children, but I've seen a couple of cases in kiddos as well. And sometimes the parents come into your practice or the patient themselves come into their practice in your practice, and they have concerns. They look up what this looks like on the tongue and they type in white lesion tongue, and you get a slew of oral cancer images. And so this is where we really are beneficial in communicating in plain terminology what this is, and putting the patients at ease in regards to their diagnosis and prognosis. So again, we have to be careful about the way we talk about these things. If you use erythema migrans, somebody's going to go home and you don't explain to them that this is geographic tongue, they're going to type in erythema migrans. And this is the first hit on Google, and it is the wandering rash associated with Lyme disease. So you have to be careful, again, about the way we communicate with our patients and make sure they understand what we're dealing with here, all right? So what does this look like? Everybody should be pretty familiar with what geographic tongue looks like. These areas of kind of papillary atrophy with the redness and a slightly white to yellow kind of serpiginous or circinate border. It really kind of goes back and forth, kind of like a snake. Typically, it's asymptomatic. The only time I get referred patients like this are when they are symptomatic, and it has a strong predilection to occur in conjunction with a fissured tongue as well. The most common location is the dorsal portion of the tongue, and this is where we'll see this more frequently, but this can be found on the soft palate, ventral tongue, floor of mouth, as well as the buccal and labial mucosa. But again, the distinct pattern that is presented clinically really gives us the understanding of what this is, and it makes you feel comfortable that you know what's going on. And regardless of location, it still presents very much the same way clinically. So this is a good example. I have a lot of photos in here, and usually I like these things to be interactive, but I know it's a lot more challenging, and we'll look at the comments and questions at the end. But this is kind of a typical geographic tongue, almost textbook example, where we have the red areas kind of, let me see here. We have these red areas of papillary atrophy and erythema, and then you have this kind of yellow-white border that really does kind of snake back and forth, and that is, again, very characteristic of this disease process itself. Sometimes the yellow-white areas can be very prominent, and you may not have that typical redness and atrophy associated with it, or maybe a little more subtle than we typically expect to see. And again, it can happen on the ventral tongue, but the clue is that kind of yellow-white border, even in the absence of the redness here, that is really striking for geographic tongue. And this is a good example of this in association with a fissured tongue. And some patients may come in with symptoms, but usually this is going to be something that they've been living with for a long period of time. And some of them may not even know that they have something like this until it's brought to their attention, or they happen to look at their tongue and it looks different for some reason or another. Here's a couple of examples out in the vestibule and involving the labial mucosa as well. Again, that classic sort of yellow-white serpiginous border with the redness associated with it. Another example here out in the buccal mucosa. And this is more so, I guess, geographic cheek or benign migratory stomatitis. But it's the same process here in regards to this inflammatory disease process that happens. And like I mentioned at the beginning, really unsure of the etiologic factor, but there's some sort of underlying susceptibility for these individuals to have this sort of inflammatory process develop. Here's a good example of this also on the soft palate. Now, the tricky ones are when it doesn't quite look like geographic tongue. And so we have these areas of atrophy. It's kind of limited to one side. We don't have as much of that yellow-white border. So you may be unsure if the patient's asymptomatic and you present with something like this. Oftentimes, the other thing we see with geographic tongue is it has a tendency to move around or kind of wax and wane in regards to its clinical appearance. And so this patient came in, the clinician thought, yeah, I think this is geographic tongue. It's nothing to worry about. It's an inflammatory process. We don't know what exactly causes it. There's really no need to actively treat it unless you're having symptoms. And so they decided, let's follow up in 2 weeks and see what you look like. And in 2 weeks, clearly a different site and a different clinical sort of presentation, which made the clinician, as well as myself, feel pretty confident that this is geographic tongue. And again, the patient's asymptomatic, and there's so really no need for any treatment or interventional therapy with patients like this. Here's one in a kiddo, and really prominent sort of yellow-white border, not as much of the atrophy or redness here, but this was an interesting case where this is the only site that the kid actually had involvement of this. And so while it's unusual, on rare occasion, you will get these sort of manifestations or this clinical disease present in kind of an atypical manner. It's asymptomatic, so we reassure the parents this is likely what this is. The patient doesn't have any cutaneous disease like psoriasis and no underlying health conditions. So we feel comfortable just monitoring this when they go in to see their doctor or dentist, and nothing else that really needs to be done for these patients. So what other diseases have been associated? And I put associated in quotes because this really is more so of a historical link with geographic tongue. But there's a process called Reiter syndrome, which we now refer to more so as reactive arthritis. And med students learn this through a proverb, and the proverb is one who can't see, can't pee, and can't climb a tree. And that's because they have variable kind of phases of ocular inflammation. They could have conjunctivitis, uveitis, or keratitis. On top of that, they have a non-gonococcal urethritis that is present in these patients, and they have reactive arthritis, okay, hence the name. And oftentimes that leads to kind of this med school proverb or quote that is used for them to remember these things. There is an associated HLA subtype with this, and that's B27, which has been linked with a lot of different inflammatory processes, psoriasis, ankylosing spondylitis, some inflammatory bowel disease also. They do have cutaneous lesions that kind of overlap with psoriasis in some of these patients. And then the oral lesions, it's been described more so as ulcers or erosive lesions. But on rare occasion, you'll see patients that also have this geographic tongue. And this link was made because a lot of these patients have an inflammatory process, particularly male patients with the glans penis that looks like the similar pattern of inflammation we see in geographic tongue. And that's called succinate balanitis. And there's an image that I'll show you in the next couple of slides of that. It has been observed in correlation with individuals that are HIV positive. So these are things to look for. When we evaluate a patient, we're not going straight to the problem, okay? We need to take a step back and do a thorough investigation of that patient's medical history and any other clinical signs or symptoms that the patient may be complaining of, because it's likely that there may be a link between what's going on in their oral cavity and possibly what else is happening to this patient at the same time. And that's very important to remember. So this is a patient who has these papular and kind of excoriated lesions on the palms of their feet, or the soles of their feet, pardon me, as well as their hands. They have the ocular inflammation, and then they have these inflammatory lesions affecting a portion of the penis that looks kind of like geographic tongue, these areas of atrophy and this kind of succinate border, this serpiginous border in patients who have reactive arthritis. So treatment. So the patients, again, majority of these are going to be asymptomatic, so there's really no need for treatment. I want to make sure that's emphasized. So you reassure the patient this is a kind of a benign inflammatory process. There's really no need to treat it. But on occasion, you will get patients that come in with symptomatic geographic tongue. One, you want to figure out, is it the geographic tongue that's really causing the symptoms? Does the patient have xerostomia? Do they have candidiasis? Do they have another process that could account for that discomfort that the patient's feeling, right? And if it really is the geographic tongue, then we can do some topical steroids and we can use a potent class of steroids like fluocinolone 0.05% gel, or clobetasol, which is the highest potency of topical steroid you can give, or in the class of the highest potency of topical steroids you can give. And that's also at a 0.05 concentration. There are some published studies where people have used elemental zinc for some of this. And so 3 to 5 milligrams of elemental zinc a day, and it increases the integrity of the epithelium and plays a role in the immune system as well. And that's thought to play a role. And then some of these studies have shown some positive effect in patients who have geographic tongue. So again, if a patient is zinc deficient or something like that, they usually have other manifestations as well. They'll have cracking of the lips, issues with cracking of the skin and painful lesions on the skin, which is a dermatitis that's associated with zinc deficiency. But this is something that you can also look into in some of these patients. And again, goes back to the point of overall evaluation of these patients. Big thing that's come up for the last 2 years now, COVID, right? So what about COVID tongue? And there were some publications out of a few different places, a few different countries that said, you know, there are some specific oral manifestations of SARS-CoV-2 infection, regardless of variant. And people were ready to publish this stuff. And looking at some of the publications, you know, some of this looks like some of the common lesions that we see in the oral cavity, like geographic tongue, like this image B here on the right. And so we have to be a little bit careful. And as far as we know, there's no causal association just yet with some of these clinical findings and SARS-CoV-2 infection. And I'm going to take just a second here to kind of talk about this. You know, COVID is something that is rampant across the world, particularly in our country at this moment. And that's something that you have to be aware of. It's an infectious process that can lead to a variety of clinical manifestations. And yes, we are seeing them with COVID or SARS-CoV-2, but there are other viruses that can produce, I shouldn't even just say viruses, there are other infectious processes that can produce similar clinical manifestations, but just by the mechanism of infection and the way it affects our immune system, as well as other systems in our body. So that association is not distinct. It can happen with other disease processes. But I'm here to tell you that geographic tongue is geographic tongue. At this point, we're not sure if there's a direct causal relationship with that and SARS-CoV-2. Recurrent aphthous stomatitis is our next disease process, and this is recurrent. So this is not just talking about your typical aphthous ulcers, okay? Aphthous ulcers in general is what people refer to as canker sores, plainly said. And there's numerous causes for a canker sore to develop. But we're talking about here is this recurrent process where a patient presents with ulcerative lesions in a cyclical manner, okay? So what is this? What is recurrent, this aphthous stomatitis or ulcerative process? Well, it's the dysregulated immune response to some sort of antigenic stimulus, okay, that causes destruction and breakdown of that top layer of tissue to cause ulcers. And there's many things that have been implicated in these individuals. So whenever it's really cyclical and it's more generalized in its manifestations, that's when you got to start thinking, okay, there has to be something that's setting this off, okay? So many things you can look into are allergies, underlying genetic factors. I ask the parents, you know, oftentimes if a child comes in with something like this, have you guys had a history of recurrent canker sores as a child, you know? And if there is a positive history, then we say there's some sort of genetic or heritable link to this. Stress can induce this sort of process, as can trauma, nutritional deficiencies, as well as infection. And this is just a small list of some of the things that are involved in recurrent aphthous stomatitis. So potential antigens, things that can potentially stimulate this sort of immune response, SLS, or sodium lauryl or laureth sulfate. It's in a lot of toothpaste as well as a handful of different products. And if a patient has an allergic or hypersensitivity type of reaction to this, they can present with this cyclical ulcerative process. There are SLS-free toothpaste that are available on the market. You don't have to go far. Many of last time I checked, some of the Sensodynes actually don't have SLS, so that's something to look into. NSAIDs, that's another one. I always ask about, you know, do you take anything for aches and pains, or have you had any sort of illness prior to this ulcerative breakout? And if the patient is like, well, I always take ibuprofen. Well, that's in the category of NSAIDs. So I get them to switch to something like acetaminophen. instead of using the NSAID. Certain bacteria and viruses can also cause this. Food allergies can interestingly also cause recurrent aphthous stomatitis without having other clinical manifestations like skin eruptions like hives or anything else that develops as a result of that allergy. Flavoring agents and preservatives are other big things that can actually cause this sort of cyclical pattern of ulcerative disease affecting the oral mucosa. So who are you going to typically see in your practice? Typically, people with recurrent aphthous stomatitis are going to be younger. Usually, they're individuals younger than 30. And what does it look like? Well, there's three clinical forms that we kind of subtype these into. One of them is minor, one of them is major, and these are depending on size. And I'll kind of elaborate a little bit more on the following slides. And then the last one is herpetiform. And this one's a little bit tricky because it kind of does look clinically like a herpes simplex virus infection or varicella zoster virus infection affecting the oral cavity. Ulcers, remember, they look like yellowish white areas, which is that fibrin membrane or the body's band-aid that develops in the area where you've lost that top layer of tissue. And usually there's some surrounding redness around that ulcerative lesion. So minor aphthous stomatitis is probably one of the most common subtypes we see. It accounts for about 80% of recurrent aphthous stomatitis. Usually the ulcers are 3 to 10 millimeters in size, so maybe up to a centimeter, that show the fewest recurrences. And these typically heal in 7 to 10 days without any evidence of overt scarring, okay? You can have anywhere from 1 to 5 ulcers. The patients oftentimes will complain once it becomes cyclical of some prodromal tingling or burning. And a lot of times I've seen pediatric patients with this in my practice, and they'll usually talk about, you know, I feel like there's something stinging or there's something different. I can feel it. It's this altered sensation they can feel before that ulceration actually manifests. And that's the inflammation that's taking place in that area that's causing this sort of clinical symptom, right? And then before that ulcer actually breaks down, or before that epithelium actually breaks down and forms an ulcer, they have that prodromal sort of feeling, okay? Labial and buccal mucosa are the most common sites, and this rarely affects the keratinized mucosa. And that's a big thing to help us distinguish this from recurrent HSV, which is something we see frequently in the oral cavity as well. This is always going to be, and I'm not going to say always, but majority of the time, this is going to be something we see on the movable mucosa, not the bound down mucosa. And bound down meaning it's bound down the bone, okay? So a couple of examples of recurrent aphthous stomatitis. We got one here in the labial mucosa, probably close to a centimeter in size. A little smaller one here, again on the labial mucosa. Here in the commissure area, and same patient with a lesion in the floor of the mouth as well. So they may have anywhere from 1 to 5, sometimes more, but typically from about 3 to 5 millimeters to about a centimeter at the most in size, and they usually heal within 7 to 10 days before they get another flare up at some point in time. Major aphthous ulcerations, these are large, painful ulcers, okay? We're talking about 1 to 3 centimeter. I've seen one even larger than 3 centimeters. It usually takes a lot longer to heal. There's a lot more breakdown of that epithelium. So it takes a lot longer to heal. And typically these will cause scarring depending on the size of the lesion when they heal. You can have anywhere from 1 to 10 ulcers, and the scarring can become an issue as it starts to cause a little bit more constriction in some of these patients. Labial mucosa, soft palate, and the tonsillar pillar area, particularly that posterior soft palate, and that anterior tonsillar pillar is a really common place for us to get major aphthous ulcerations. So here's one, and it almost looks a little bit more nodulo-ulcerative. There's a little bit of kind of bulk to this lesion, large lesion, and that while it is heart-shaped, this is not fun at all. These patients come in with significant pain, and you can only imagine what this does in regards to being able to chew, swallow, talk, for these patients. Herpetiform, this is the one that probably has the most, temporally close outbreaks cyclically. So that means they, by the time some of the ulcers are healing, they'll have a new flare-up that comes in. These are really small ulcerations, no greater than 3 millimeters, but if they're close together, they may have a tendency to kind of coalesce. And this looks like a herpes simplex or recurrent herpes infection. But the other thing is, more often than not, it has a tendency to occur on the movable mucosa. Typically heal between 7 to 10 days, but again, by the time they're healing, they may have another flare-up. And you can have as many as 100 ulcerations during an outbreak or a flare, all right? Some studies have shown a little bit more of a female predominance and a little bit of an older age at onset with this specific subtype of recurrent aphthous stomatitis. So this is one here on the soft palate. We have multiple sort of punctate type ulcerations, which I could clearly see being confused for herpes simplex more often than not, unless the patient is immunocompromised. In immunocompetent patients, we're going to develop recurrent HSV lesions on the bound down mucosa, not on the movable mucosa. It's only when they're immunosuppressed that they'll have a tendency to have this more atypical manifestation of the recurrent herpes outbreak. Here's one, lower lip, again, multiple sort of punctate little ulcerations. I have one down in the vestibule here that's also hiding out, but it does have that kind of punctate pattern that we see with herpes simplex. So when you have a patient with a recurrent ulcerative disease process that is in this category of recurrent aphthous stomatitis, I always look at systemic issues as well, particularly in younger patients. So there are a handful of different diseases that can lead to this manifestation. Inflammatory bowel diseases lead to malnutrition, and so you can have nutritional deficiencies. And so secondary to that inflammatory bowel disease, they'll have recurrent oral ulcerations. And so oftentimes I'll talk about gastrointestinal symptoms and whether they've seen a gastroenterologist in the past. Behçet syndrome is a vasculitis that occurs in some kids as well as adults. And this is a disease process that has a handful of other clinical manifestations, which I'll go into in the next slide. But there's a handful on here that some of you may actually recognize. Celiac disease, fairly common, and that can lead to recurrent oral ulcerations, and in many cases as a result of malnutrition in those patients as well. So whenever a patient comes in with this, I really like to spend my time looking at their clinical history, talking to their physician or their primary healthcare provider to make sure that this oral manifestation is not of something that is systemic going on in this patient. So Behçet syndrome has a slight male predominance. And again, it happens kind of in the 20s and 30s, so younger individuals, but it can happen or be manifested in older individuals as well. Specific HLA subtype. So HLA is the way our body reacts to certain antigens. You may be allergic to hay fever, I'm not. And that's because innately, your body has reconfigured some of those cells to recognize the antigen in hay fever as foreign. And so now you mount a specific inflammatory response to that. And my body was not configured that way. So this is something that is genetic as well as undergoes rearrangement through the course of development early on in life. And so just because you have this HLA subtype doesn't necessarily mean you'll develop the disease. There usually is an environmental factor or some sort of multifactorial process that leads to the development of a specific clinical disease. So no clear cause has been established, but this is, again, Behçet syndrome is considered to be a true vasculitis. And one of the big criteria for this, or criterion for this, is ulcerations, recurrent oral ulcerations. And in many cases, that can be the first manifestation in a patient coming into your practice. So a lot of patients that I get referred from pediatric rheumatologists and dermatologists will have recurrent oral ulcerations, and they've already been worked up for Behçet's and a handful of other things before we get to them in our practice. They often present with orogenital or ocular involvement. And so there's a certain criteria to make this diagnosis, and it usually requires the oral ulcerations plus two of the following here in this chart. So you can have recurrent or anogenital ulcerations in these individuals, eye lesions, inflammation that happens. They develop a handful of different skin lesions that can occur. And then you can also do a pathogen test, which is done by a physician where they inject a little bit of saline into the skin or just inject a needle and see how responsive you are to that to make this diagnosis. And again, they also kind of evaluate to see whether you do have that specific HLA subtype. So first, when we're treating these patients, you got to attempt to determine a cause, right? So rule out any underlying systemic diseases. And that is a big list. And that's why this is truly an opportunity for multidisciplinary approach and involving the remainder of the healthcare field outside of those of us that are just oral healthcare providers. And at the end of the day, if we can't determine a cause, there's variable methods that are alleviated at, alleviate or kind of focused at alleviating their symptoms. And it's based on the severity of these symptoms that these patients suffer. You can use topical or systemic steroids. On the larger lesions, you can use intralesional steroid injections. And then there's more heavy-duty medications, such as TNF alpha inhibitors, which can help directly. And these, again, are in the class of immunomodulatory type of medications for the patients who have this consistent outbreak without an underlying cause that's been determined. So moving on to allergic reactions, this really is a heterogeneous group with variable types of hypersensitivity mechanisms. And it can be to systemic drugs, dental materials and metals, flavoring agents and preservatives. It can be to a handful of different things. So there's two basic types of reactions to any medication that you're taking. One is the exaggerated but expected response. And the classic example I give is warfarin. If a patient is on warfarin and they undergo surgery, you expect prolonged bleeding. And that is a direct expected response from that medication, given the mechanism of action. But then there's this whole category, which really messes things up, of idiosyncratic responses. And so these are adverse sort of hypersensitivity reactions that develop. And that can include anything that looks kind of non-specific, like ulcerative diseases, to things that can mimic autoimmune diseases to the T, to the point where they actually produce autoantibodies. And so you can have pemphigoid and pemphigus-like reactions. Those are the skin blistering diseases that can also affect the oral mucosa and other mucosal sites. You can have lupus-like drug reactions as well. And then again, like I mentioned before, you can have these non-specific ulcerative reactions in some patients. This is a patient who had persistent kind of bullous formation on the tongue every time in kind of the same location, and everybody was scratching their heads. And this was from one of my mentors. And he said, what correlates with you having this onset? And the patient would cyclically get an upper respiratory tract infection for which they would be prescribed antibiotics. And after that, they ended up having this outbreak. So it just took a little bit more digging into the history to figure out that, hey, this could be associated with the antibiotics that you're taking. And this patient did undergo a biopsy of one of these sites, which histologically was suggestive of a fixed drug type reaction. And it was another piece of this kind of diagnostic dilemma or puzzle that gave us evidence to say that, hey, maybe this is associated with medication. And in this patient, they stop the medication and you get complete resolution. I'm a very conservative, old school clinician. I like to take my time with patients and think about, is there a cause? I feel like too frequently, and I give this feel to all my patients, too frequently we go into a practice and we don't get as much face time as we should with the clinician. And you say, okay, my right knee hurts. And more often than not, the response is, well, let's try a course of steroids, let's get you back in a couple of weeks. That's not good enough for me. Okay, I was raised in an environment where we got to figure out why your knee is hurting and then try to address the problem in a more focused and methodical manner. And so it really does take time, but it is time well spent. Because if you don't have to give the patient a medication for the rest of their life, and you can eliminate, let's say, a source, man, I'm happy. We've done our job, right? That's the true meaning of providing comprehensive healthcare for these patients. This is a patient from a colleague of mine, and I'm sorry the picture is so pixelated. I did not think it was going to translate like that, but it developed these white lesions. This is one kind of in the buccal mucosa. He had a little bit more whitish change that was more reticular, kind of spider web-like in his buccal mucosa on both sides. We just have this area here. So this was biopsy. And histologically, it looked like lichen planus. There are specific things we look for as pathologists, and this looked like lichen planus. So I called the clinician. I said, any chance he started any medications, anything that he's allergic to, anything in his hygiene products that's changed that kind of correlates with the onset of this? And the patient was just recently diagnosed as a diabetic and was given oral hypoglycemics. And guess what? Oral hypoglycemics are in the category that can cause a lichenoid type drug eruption. And this patient didn't have skin involvement, just the oral mucosa. So I recommended, hey, we talk to the physician and switch to a different class of medication, or if possible, we try to stay away from insulin, but if this is a possibility for this patient, let's try and do something like that. So they switched the patient to a different class of medication, and all of his oral disease cleared up within a span of about 6 to 8 weeks. So again, you're going to treat this, especially if the patient is symptomatic, with steroids, right? And if we can eliminate having a patient be on chronic corticosteroid therapy, even if it's topical, I think it's extremely beneficial. And so taking the time to kind of put the pieces of the puzzle together are really, really helpful for these patients. This is a patient who had these recurrent ulcerations that were persistent, would not heal. They tried intralesional injections and they got some resolution, but another one would break out. And we looked at the patient's medications, and the patient is on methotrexate, a classic drug that leads to the development of ulcerative lesions that can affect the oral mucosa. And this is all the patient had, just oral mucosal involvement. Got the patient off of methotrexate. This is 3 weeks later. Better resolution that they were seeing with any topical and intralesional steroid, and they completely resolved by the time 6 weeks rolled around. So again, making that correlation and establishing that link is really important for these patients. I will take a moment real quick right here to stop and just talk about a patient I saw. He was a 2-year-old male that was referred to me for recurrent oral ulcerations. And I could have talked about this, I guess, with the aphthous stomatitis, but I wanted to bring this into the allergic category. And so I sat down with the parents. The rheumatologist was ready to start the patient on an immunomodulatory medication, which is a pretty heavy duty medication. Limited side effects, but still it's a systemic medication for a growing child. And so I did an extensive kind of deep dive into their history. And I started with anything that they're using intraorally for hygiene. Toothpaste and things like that are usually pretty high on that list of offenders. And I determined, it doesn't seem like the hygiene product is really doing it. I said, is there anything that, the kiddo has to have at every meal? And the parents looked at me and they said, well, he has to have tomatoes, whether it's ketchup or just sliced tomatoes. He just loves tomatoes, which I thought was crazy. My kids don't like tomatoes. So the fact that this 2-year-old just wants tomatoes is impressive. So I said, how about we do this? Let's try for 2 weeks, just removing tomatoes from his diet. He might not be happy, but let's see what happens. And so we did that along with a food diary and this kind of counseling for certain dietary restrictions. And the mom called me 3 days later and said, this is the first time he's been without another outbreak in the last 2 years, right? And so it was a tomato allergy. We got the kid tested, and the patient actually had a tomato allergy. And this was his manifestation, right? So we've avoided the systemic immunomodulatory medication in this 2-year-old child by eliminating something from his diet. And that's a big win. It's not always that easy. And I'll tell you, it's majority of the time, it's not that easy. But when you're able to do something like that, I think it's a huge benefit for the patients, the family, and for us as healthcare providers. So mucosal reactions to dental materials and metals. This is a fairly common one. Typically, we see this as a type 4 hypersensitivity reaction that can look very much like lichen planus, or what we call a lichenoid type reaction. It looks like lichen planus. The most common offending agent is amalgam, and it's also not just mercury, but the silver alloys that are in the amalgam. And as they erode or corrode, it releases these metal ions. And as those metal ions get released, they pick up with other proteins from your epithelial cells, and your body sees that as foreign and starts attacking those epithelial cells. And so this is a fairly common one. And I'll show you a good example, of this. And there's a patient, symptomatic, talks about pain and burning in this area, and it's just associated, there's another little lesion associated with these buccal amalgams. So they was biopsied and they thought, man, this looks like, a lichenoid type reaction. I would correlate clinically with any sort of dental materials or metals, flavoring agents, things like that. And the clinician said, well, I think it could be the buccal amalgams. So they replaced the buccal amalgams. And within 2 to 3 weeks, we saw resolution without any systemic or topical chemotherapeutic, like a steroid or anything like that. So again, eliminating a source is far superior to actually and far superior to chronically managing a patient for something like this. Preservatives, cinnamon is the big one. This is the one that I spend most of my time on. The concentration of synthetic cinnamon is almost 100 times more than what we see with natural cinnamon, and inevitably a portion of the population reacts to this. So ice cream, alcoholic beverages, sodas, particularly in Texas, Dr. Pepper is a big offending agent for this. Dental floss, toothpaste. Toothpaste is another big one, particularly those that are tartar control. Tartar control toothpaste uses an active ingredient which is masked with synthetic cinnamon, and it's not on the list, but when you look at the ingredients, that's not on there, but they mask it with synthetic cinnamon, and then they put their flavoring agents or natural flavoring agents in there. So that's something to be aware of in patients who present with a mucosal type of reaction. The other thing to look for on occasion is lesions that are unilateral. And when I say that, I mean on the tongue and the cheek in the same side, right? A lot of times, like we have a dominant hand, I'm right-handed, you may have a dominant side that you chew on. And so if a patient, let's say, is chewing on Big Red and they chew on it on their right side, that is the area where you're going to have the highest concentration of that flavoring agent. And as it dissolves, it goes into your saliva. One, it's in constant contact with your cheek and your tongue on that side. And so you have the highest concentration on that side. And more often than not, you'll have a more exuberant reaction in that sort of unilateral clinical presentation. So we see a lesion here on the left side of the tongue. This patient also had a lesion on the left side of the cheek, and it was associated with a mint that he used to suck on that side and just kind of place it in his cheek throughout the day. Here's a patient, and these are intraoral photographs, so my apologies, but not the best quality, but I think it kind of drives the point home. This looks scary. I mean, this is an ulcerative process. Patient had a similar lesion on the tongue, which was even a poorer quality intraoral photograph than this, so I decided not to include it. Unilateral, only on that right side. And this patient, when they asked about diet, any sort of gums and mints, avid Big Red chewer, goes through like a pack, within 2 days. And so they told her to stop using it, and complete resolution within a short period of time. So again, compared to having to treat this patient with systemic or topical medications, eliminating the source goes a long, long way for these patients. Here's another patient, and this is a really great example of that unilateral involvement. We have involvement of the tongue, and you can see this side of the cheek as well. And here's a better picture of the cheek. And it's right along that kind of middle area, right along the occlusal plane, where you're going to get the highest concentration of any sort of allergen. So desquamative gingivitis, this is our last kind of category before we talk about lupus and finish up. Desquamative gingivitis is a clinical term we use, and it's descriptive, and it includes a handful of different things that are in your differential diagnosis. So these are the patients that come in with red-white lesions that are ulcerative, may or may not be ulcerative, affecting the gingiva, okay, hence the name desquamative gingivitis. And our differential for that includes lichen planus, mucous membrane pemphigoid, pemphigus vulgaris, and allergic reactions, okay? And that should be something that should be a real take-home point and kind of driven into the back of your mind about what you see or what you should consider when you have a patient walk into your practice with this sort of clinical appearance. So lichen planus, the first disease process we're going to talk about. It's an immune-mediated process. Some people think it's autoimmune, but we haven't really found an autoantigen for this. So we consider it to be immune-mediated. That means it is a clinical process mediated by some immune dysregulation, and it causes destruction of our epithelial cells. Really unknown etiology. It can affect the mucosa as well as the skin. Typically, we see this in middle-aged females. And we can see this in the pediatric population, but oftentimes when we see it in pediatric population, it has a stronger predilection to occur in males. So again, more often than not, this is going to be a middle-aged female that walks into your practice with this clinical presentation. There's specific patterns, and everybody probably is aware of some of the more classic ones, like the reticular spider web-like appearance that we see in the cheeks. There's an atrophic, erosive, or ulcerative pattern, a papular plaque-like, and then there's this kind of interesting one called bullous. And now there's some thought that maybe this bullous pattern, where you form a blister, may actually be part of a disease process called lichen planus pemphigoides. And that is a disease process which really is in the category of pemphigoid, but it has some overlap with lichen planus. And initially it may start out as lichen planus, but eventually you develop autoantibodies and you truly develop an autoimmune process that is within the category of pemphigoid. Where do we see this? Buccal mucosa by far is the most common site, followed by the gingiva, but it can affect the tongue, the palate, the lips, and clearly this is mucocutaneous, so it can have skin manifestations as well. Classic reticular pattern here, where you get this kind of white striated or reticular appearance, kind of looks like spider webs, and it's bilaterally in the buccal mucosa. When they have just this sort of white pattern, many of these patients may be asymptomatic, okay? And there's kind of two schools of thought whether we need to treat it at this stage or not. I'm of this mindset that we don't necessarily have to actively treat it unless the patients have a symptom. And that's because we don't know what's causing it. Why add additional medication to it? But the counter argument to that is this is causing inflammation and destruction of those cells. So if we allow this to continue, we could be creating an environment where the epithelium is more susceptible to other changes that can be not good for this patient going forward. Here's another patient. We have both kind of that white kind of pattern as well as more of the erosive lesions. The plaque-like lesions often affect the tongue, and we see this white kind of sheen affecting the tongue. I'm going to keep an eye on this chat as well just a little bit. But oftentimes you see a little bit of atrophy on the tongue and this sort of white plaque-like appearance. Here's one that we have true ulcerations in a patient, and you can see that sort of striated pattern or that feathered type pattern, which is a little bit of a clue that is this lichen planus or in that category of a lichenoid process. Okay, it could be an allergy. Here's another patient. You can see the striations coming off the ulceration, as well as other buccal mucosal involvement in that patient. Same here, a little faint, but you can see that reticular pattern, and clearly the patient has an area of ulceration as well. This is more of that papular pattern where it looks like little punctate areas of white change, but it still has a hint of that spider web-like appearance in the buccal mucosa also. This is one that's oftentimes referred to as pigmented lichen planus, and it really is this white change, but the inflammation often causes a post-inflammatory melanosis. So inflammation stimulates the melanocytes, which are the cells that produce the pigment, and then it breaks down. So it stimulates increased melanin production, so these areas get pigmented, the cells get damaged, they leak that melanin pigment down into the connective tissue, and so the patient presents with these kind of pigmented areas. But if you pay close enough attention, you'll see kind of these white changes and areas of redness in these patients as well. Classic patient, they have the oral mucosal involvement, they have skin involvement on the lip, and also they have the skin involvement elsewhere. And you may or may not have learned this, but these are the purple pruritic polygonal papules, and they kind of look purplish, they're itchy, and they kind of have a polygonal shape to them, oftentimes seen on the flexor surfaces of the arms and the dorsal surfaces of the lower extremities. And you would be mistaken if I wasn't a good pathologist that, I'm going to show you some histology. So this is some classic lichen planus. We have the superficial inflammation here, or this infiltrate that causes damage to these cells. Looks very much like this lesion on the right, which if the clinician said this was lichen planus, I would say, okay, this is compatible with lichen planus as a pathologist. I'm here to tell you that lesion on the right was actually taken from this lesion here, an isolated process affecting the right mandibular gingiva and buccal mucosa. And they sampled here, which is the image I showed you before, and they also sampled here. This is a precancerous lesion, okay? And this sample actually showed evidence of dysplasia, which is the microscopic changes or histologic changes we see under the microscope that indicate this is a precancerous process. And so you really do need clinical correlation to make the diagnosis of lichen planus. Histologically, so under the microscope, there are many disease processes that can look like lichen planus. As a pathologist, I wish that when we looked under the microscope, it would just tell us that, hey, this is what's going on. That's not the case. Graft versus host disease, lupus, chronic ulcerative stomatitis, which is an autoimmune disease process, allergic reactions to drugs or preservatives or topical substances like flavoring agents can all cause this. And the last thing is dysplasia or precancerous lesions can also have this pattern of inflammation. So again, clinical correlation is very much needed to make that diagnosis. There was a proposed checklist from a paper that's been about 4 or 5 years ago that talk about clinical correlation when you do a biopsy. So if you do a biopsy, you want to make sure you're clinically correlating and have ruled out a certain amount of things when you send that in, and give that information to the pathologist so they can make an accurate judgment about what's going on and can aid you in getting to a definitive diagnosis. So treatment for lichen planus, we typically do topical steroids. You have to be aware that it increases the risk of candidiasis in some individuals. Also, there are some rare cases where you can get mucosal absorption of that topical steroid, which can lead to a lot of things in regards to adrenal suppression. And I've seen one case in the past that the patient was abusing the topical steroid and taking systemics unbeknownst to the clinician and ended up developing adrenal suppression. So making carrier trays that go up to the vestibule if they have gingival disease for the steroid is really great because it can help get more substantivity of that medication. Lidex, clobetasol, these are medications that we use. You can also use an elixir. And then maintaining oral hygiene. Anytime you have a patient with gingival inflammatory disease, these patients probably need to go see their hygienist for prophylaxis 3 to 4 times a year. And I would stay away personally from any sort of polishing pastes because those have a handful of flavoring agents and things like that in them that can just exacerbate their disease process. All right, hang in there. We're right near the end, and I know we're running close on time. And Beth knows that I'm kind of notorious for this, so I'm going to try to wrap this up. Pemphigus vulgaris is a mucocutaneous autoimmune disease process that leads to blister formation. Inevitably, these individuals have skin involvement. So I will tell you up front, you're going to have to manage these patients for their oral disease if needed, but they're going to need to be seen by a dermatologist. A lot of times their oral manifestations happen prior to their skin involvement. So oral healthcare providers that are here today, they may present with just oral disease. And again, if we can get a definitive diagnosis, then this is something that they're going to have to follow up with a dermatologist. Typically, again, middle-aged females have a higher predilection for developing this disease process. You see irregular erosions and ulcerations, and the Kolsky sign, which is where you can induce a blister in a perilesional area or a normal appearing area where you push on the skin and it will just fall away. That's called a positive Nikolsky sign, and you'll see that in pemphigus as well as pemphigoid. All the mucosal sites are affected. The buccal, labial buccal mucosa, and the tongue are the most common sites of involvement. And again, 50% of these patients will have oral involvement prior to skin involvement. And this is what these patients look like. It looks like their skin is just falling apart. Their mucosa just is falling away. It's just truly desquamating. This patient had some intact blisters or bullae in their oral cavity as well. And you have to be really careful when you're examining these patients, because if you put a mirror in their mouth, there's a chance that mirror is going to stick to that mucosa, and when you go to pull that mirror out, that skin is going to come with it, and it's not going to be fun for that patient, and you're going to feel awful. So this is a patient who has skin bullous formation or blister formation as well, and this is an area that didn't look lesional, and if you just put a little bit of pressure on it, you can actually cause that skin to just rub away, and that is what we call a positive Nikolsky sign. So again, it just looks like their tissue is really just falling apart. This is one they put a tongue blade, and when they removed the tongue blade, they just scraped a large area of the mucosa away, or that epithelium away. Histologically, if you remember, pemphigus attacks the cells themselves, the epithelial cells, the junctions between the epithelial cells themselves. So it's a blister that forms above the basement membrane within the epithelial cells. And we usually use immunofluorescence to tag the antibodies. So all these areas that are highlighted are immunoglobulins that have deposited and are attacking those desmosomal complexes. And it looks like a chicken wire pattern under immunofluorescence, which is very characteristic for this disease process. Inevitably, it is systemic or mucocutaneous, so you will need to have systemic approaches to management. There's a handful of different systemic medications that are used for this. And again, proper oral hygiene, increasing their hygiene visits to 3 to 4 times a year is absolutely necessary for these patients. Pemphigoid is a disease process similar to pemphigus, except it attacks the epithelial cells that are at the basement membrane, and it attacks the proteins in particular that anchor those cells down to the basement membrane. So not the cells themselves and the complexes between one another, but the cells that anchor the epithelium down to the basement membrane of the connective tissue. Same sort of demographic for these patients. And this is where this happens, right at that junction of the epithelium here and the underlying connective tissue. And there's a handful of different proteins that can be attacked as a result of this disease process. Typically, similar presentation, large ulcerative or erosive lesions. Inevitably, these patients have gingival involvement. Gingiva is actually the most common place where you will see this sort of disease process manifest. And pemphigoid is more likely to affect the oral cavity than pemphigus. So we'll see patients like this present to our practice frequently. I just started last week and I've seen 2 patients on a referral basis already. And this patient does have an active bulla here in this area, this blister that's formed in there. Another area of blister formation in a different patient, and multiple blisters on the soft palate in areas where we have ulceration. This is a patient who was a colleague of mine, and you can literally pick that tissue up and just push it away. And it literally, these are the toughest biopsies to do. They're challenging, and they do require immunofluorescence studies, not just basic histology, just like pemphigus in many cases. So this is where the blister forms, not within the epithelial cells, but below it, and between that epithelium and the underlying connective tissue. And the immunofluorescence pattern is very different. It doesn't look like the chicken wire pattern up here, but it deposits right at that junction of the epithelium and the connective tissue where that separation actually happens. This is a patient provisionally diagnosed as having lichen planus for years and was misdiagnosed. They did not do a biopsy. He was finally picked up by a dermatologist and they found out that he actually has pemphigoid. By the time he was referred to me for management of his oral disease, he had such severe ocular involvement that they developed these areas of scarring, which inevitably leads to blindness in these patients, or it can lead to blindness in these patients. These patients will need to follow up with an ophthalmologist once a year to make sure that there's no evidence of conjunctival involvement. And so, again, this is a multidisciplinary approach to management of these patients. There's a handful of topical and systemic medications that can be used, and maintaining proper oral hygiene is, again, one of the foremost things we need to remember. So going over that differential for these patients that have desquamative gingivitis, lichen planus, mucous membrane pemphigoid, pemphigus, and allergic reactions is what we need to think about when patients present to your practice with something like this. Last category, lupus erythematosus. This is a tricky one. Systemic lupus erythematosus is a multi-system autoimmune disease process with variable behavior. It is unpredictable and it is hard to get the diagnosis in many cases until the disease is manifested a little bit later on and more efficient, or I should say persistent, in regards to the manifestations. It affects the skin, but it can affect different viscera or organs, as well as the joint and the heart. Strong female predilection, particularly for African Americans, and the onset is very early on. So we're talking about 4th decade of life in the 30s. And oftentimes they'll have skin and other signs of disease, and they do blood work, and the blood work may come back inconclusive. Or alternatively, they may have blood work that's supported, but they don't have any evidence of the disease, especially early on in that disease process. So it's a little bit harder to get the diagnosis. Who are you going to see? It's easy to recognize in a young woman who has that butterfly or malar rash that we learned about. And that's a result of that sun damage and this autoimmune reaction to the areas of that damage. But sometimes it's a little more subtle and it's puzzling. You can have these lesions that look like lichen planus, not just clinically, but on biopsy, and it can lead to scarring as well. Lots of different manifestations, including fever, fatigue, weight loss, all very nonspecific and requires further clinical investigation. Classically, the malar rash in a patient like this is going to be easy to diagnose, but it's never really that easy. If you have something like this, it makes our job much easier. Non-specific red-white lesions in the oral cavity that can look like lichen planus on biopsy, but it really is a sign of lupus in some of these patients. Treatment's going to inevitably require systemic therapy, topical steroids, and again, maintaining proper hygiene for patients who have oral mucosal disease. Increasing those hygiene visits to 3 to 4 times a year is extremely important. And that is it. You guys have been fantastic. I appreciate the patience that everybody has had. I know it's a lot of information, but I'm going to end with this, and I always end with this because this was given to me by a patient who had pemphigoid, who I'd seen And third appointment, she walks in, she says, "I know your secret, Dr. Patel." And she gave me this newspaper clipping, which said everybody loved working with Dr. Patel, and the guy's holding the paddles saying beer. And so that is all I have for you guys. Thank you so much. I know we're right on
Yes.
the clock. So I appreciate everybody's patience, and thank you, Beth, and Texas Oral Health Coalition for this opportunity.
Well, thank you, Dr. Patel, and we're just right on the nose. Again, your slides are just marvelous. I always learn so much from you. Thank you so much for your time today and for presenting for us.
Oh, my pleasure. Take care, everybody.